Now, this is the panel discussion on medical legal issues, and you may notice that it's a little different than what all of the other videos, because it's actually being recorded live in a studio, otherwise known as Babalu's room, X room, for some technical reasons where we weren't able to capture it on the at the real courses. Let me introduce to you, on my left, the senior member here, Dr. Gregory Henry. On the right, the junior member, Dr. Mel Herbert. It's interesting, actually, that the three of us are here because those of you who are interested in this topic, and by the end of the hour you may not be, I want to tell you a little bit about Risk Management Monthly. It just so happens that the reason we're recording this today is because we're recording one of the issues of Risk Management Monthly. If you would like to get a monthly CD that will scare you about why you don't want to like to practice anymore because you're going to get sued or those kinds of things, or actually avoid getting sued, or something to that effect, you might be interested in Risk Management Monthly. Our website is entitled riskmanagementmonthly.com, oddly enough, riskmanagementmonthly.com. Clever, huh?
It's very long.
Yeah, this is shameless, Ricky, but
promotion?
Let me just tell you, if you're interested in medical legal problems in emergency medicine, we're part of your solution to that problem. Every month, you get to hear cases discussed, updates, wine of the month, all kinds of good things which have to do with not getting sued in emergency medicine.
All right, that's it. Okay, that's right. You want to chime in here, or you've had enough of this shameless?
No, I think it's
all
wrong.
Right.
I'm against this.
Oh yeah, right. Yeah, we know.
I'd
that
never do this.
You never do any kind of thing like this. Right. So what we're going to do is we're going to go through the chapter from the Series 27 course. We're going to pick and choose. The nice thing about doing it in the house here, actually, is that there's no audience. And the bad thing about doing it in the house is there's no audience. And so when there's an audience and they ask a question, you can't hear what they say. So that won't be an issue. But now we have to basically do this without any help whatsoever.
It's very difficult. But we're going to do it.
All right, it's okay. The first one. Who's got that?
I got number one.
Melvis, okay.
And it goes this way. It says, a longitudinal study of emergency medicine residents' malpractice fear and defensive medicine by Rod Rodriguez, Academic Emergency Medicine, June of 2007. Rod Rodriguez is very famous. You know why? He was my senior resident at UCLA. He's very smart. He's triple boarded. Emergency medicine, medicine, and critical care.
Yeah.
And he did this thing. So this is it's a nice little study that asks a few interesting questions. And it looked at the fears and thoughts about medical malpractice of 46 emergency medicine residents at 5 different residencies. Asked them to complete a survey when they're an intern and then at the end of their residency. And they try to get a feel for what people's malpractice concerns were at the beginning of their careers and then sort of 4 years into it after they'd done their residency. And first of all, they stated the concern about malpractice, worried about getting sued, was not an influence in them deciding to do emergency medicine or not emergency medicine. That was the first thing. Then they said, how did they feel about medical malpractice as an intern? They were pretty worried about it. They were moderately concerned about seeing patients screwing up, getting sued. And what's interesting is that at time, as they went through their residency, that concern remained, but it was significantly less so. They seemed to have worked out that this is just part of the job and they weren't as anxious about it. And I can tell you, from my experience, that's how it was when I was a lad. I was really worried about coming to America. Oh boy, everybody gets sued. And then as you go through your training, you realize it's just part of the job and there's some experts that can teach you what to do to reduce your risk so it doesn't become as big a deal. So this isn't, landmark science here. It's just an interesting little survey of what these guys thought. I think it was interesting.
I think it may be less than landmark science. You're right about that. And what isn't expressed here is what happens when they're 3 years out.
Right, that'd be the nice
follow-up. This is the problem. As a resident, the chances you're going to be around when the lawsuit hits and gets tried is very small. If you're looking at the state of Michigan now, we're trying 2002 cases in 2008. So they're now out and they're gone. They haven't had a problem. Here's what you ought to do to run this study, is sue them, or at least pretend to sue them on the second day of their residency. Just put their name on a summons and complaint on any case they've seen, and now see what they think about it. I think that until you've had your first bite at this apple, you're not gun shy. You don't know what goes on, and the problem with all training centers is that they're a protected, sheltered environment where they never get to watch the money's being paid forward for the malpractice insurance policy, that sort of thing. I honestly think that it's good to know what happens in the residency. This would be a great study if it followed those same residents, looked at year 3, year 6, year 9. I mean, let's make a Framingham type study for malpractice, because I think it gets worse in years out, not better.
Yeah, certainly they are in a protected environment. What if you're working in an emergency department as the only doctor? That's totally different than being a resident where you have a senior resident, junior resident, freshman guy, a staff, faculty, consultants. You're just insulated from all that stuff. So I think that they don't know any better. They have this kind of baseline fear of being sued, but in the environment that they're in, nobody's getting sued and they don't hear about it. And they're way down on the pecking list. So I'm not so sure how we can extrapolate this into practice after residency.
You made a good point, and that is about 90 to 93% of the hospitals in the United States are not training hospitals. Most of them have to go out and get something as frightening as a job.
No.
Yeah, I guess, I'm sorry.
They're going to stay in academics
and I'll
forever.
tell you, the difference between being an emergency doc
teachers
who has every specialty upstairs, and you can call down the expert in the left testicle to take a feel and see what they think, and practicing in a private environment where if you're calling people in willy-nilly, your job could be on the line. I think that those kinds of situations, if you've never practiced where you're the only doc in the hospital and you have to call people, private attendings in to see things, that's when badness can happen. Because then you're a little less likely to call someone in, even if you may need them. And I think all of those lend to the malpractice problem when you're out of the training program.
I was trying to keep it light and breezy and quick. At this rate, this video will go for 4 hours.
Yes.
Yeah, we have 15 papers. We've never gotten through all 15 papers. We just may, however,
not a problem
during this hour.
Paper number 2. Litigation of missed cervical spine injuries in patients presenting with blunt traumatic injury. There's only one problem with this paper. It's published in neurosurgery, and it's published by neurosurgeons, which means they see the 1 to 2% of major trauma patients that we send to them. By the process of selection, they're the end of the funnel. And so when they look back in this study, and what the study does is it looks back at the Barrow Neurologic Institute in Phoenix, and they look at 20 cases of missed cervical spine fractures or injuries which were sued on over a period of time. In 8 of the cases, the physician was released in some way, did not have to pay the money. 12 of them were major payments averaging $2.9 million. They move on to point out some good things. In virtually no case were they sued for not doing a study. Somebody got something. And quite frankly, the plaintiffs often don't know what study should have been done. But in at least 6 or 7 of those cases, those 12 cases, there was something on the x-ray, there was something seen which they either failed to recognize on the initial pass or failed to do something about. They do conclude this paper with a line which I think is worth talking about, and the authors stress the indefensible nature. I never want to see that in a paper. There are lots of reasons that things happen, but they talk about the indefensible nature of failing to recognize an injury identified on an adequate imaging study. The paper then goes on to talk about what the average physician is getting now as opposed to in the past as far as a study. Should it be the CT as the basis? And there's really a couple of good arguments at the end of this paper, which have to say, you know what, we shouldn't let the law push us to making what is the standard of care in the practice of medicine.
I do think it's worthy of discussing, though, because a year ago in the course we did a half hour on is the C-spine x-ray dead? Because when you look at the literature on this, if you really want to know what's going on in the C-spine, you don't take a plain x-ray. So the question is, when do you take the inadequate test and when do you put in the good test kind of thing?
It's
you
inflammatory state.
You take the inadequate, you take the not as good test when you know that it's going to be normal and you're going through the motions.
You know, I'm a conservative about testing, but I will tell you this. as far as I'm concerned now, if there's any serious consideration of a C-spine injury, shoot a CT. Here are the reasons. Number one, the new helical CT is faster than shooting the 5 views of the neck, and everybody's shown that. In fact, if you look at cost, not charge, the only thing an economist is interested in is cost. The actual cost of doing a helical CT is cheaper, as Mel would say, than doing a 5 view of the neck. It takes less tech time, and if you look at the Nexus trial, there was no question that there was a third of injuries missed when you compared the CT and the plain films of the neck. As far as I'm concerned, if there's any serious suspicion, get the correct study.
So that's the key point, though. Don't take away from this that it should be your screening tool, because it's all about the radiation, and it's all about filling up the scanner with low-risk patients. Because for all the blunt, even at a major trauma center, of patients who come with blunt head, chest, neck trauma, only about 1 to 4% of those people have a fracture. So you're going to be scanning 99 people who don't really need it. So Nexus said, and I think this is still true, it is true, in low-risk patients, plain films are a good screen, but as you said, once you've decided I'm worried, CT is clearly better, but I don't want to scan everybody.
Mel, you ignorant slut. If they are low risk, they probably don't need any study at all.
No.
Then what you're treating is their psyche, not their cervical spine.
No, what you're suggesting then is you've got a dichotomous, if they're Nexus negative, do nothing, and if I'm going to image them, I go straight to CT. I don't think that's where we should be yet.
Well,
I think there's a lot of people with a little whiplash where they might have a little midline tennis. I still don't think the probability is very high. Getting a plain film reduces that chance further.
Mel,
getting CTs on all those people.
Mel, I'm not sure doing a plain film does reduce that risk.
Well,
I haven't seen that study.
Nexus to 34,000 patients said that.
Well,
Yes, honestly, yes, but when you look at Nexus, when they look at the small subset of people who had fractures, there was a disproportionate miss rate. On those
But the entire point of Nexus was there is a downside to CT scanning. That downside is cancer. There will always be a miss rate. Do you really want to do CT scans on everybody where you want to do some imaging of their neck?
You know, this reminds me of the drunk who's searching for his keys under the street light. Now, he lost them in the dark, but it's dark out there, so he's going to look under the street light. What I'm saying is, I think that if we think somebody is a serious candidate, if it's tender when we feel them, they don't want to move their neck, I have no problem in moving first to the correct study.
Well,
I really don't.
I just think that's inflammatory for people who work at these little tiny hospitals, who don't have CAT scanners like I've got 5 of them, who still the screening tool is, and Nexus says it's okay to do that if there's more concern, if there's a fracture, if it's a high-risk mechanism, if you've got a little old lady with a unibray, sure, go to CT scan first, but I don't want to set a standard of care that many people cannot
Well, fortunately, we don't get to set the standard of care.
We don't get to set it. Exactly.
So did we get anything out of this?
No, but it was fun to
Well, I think that is the core of the issue is there's no question that CT is the better study. There's no question. That being the case, there's this incremental cost, and there's this thyroid radiation kind of thing which is, and many of these people who have neck injuries are relatively young people. They're out doing things under the influence of excess testosterone mixed with alcohol, a deadly combination.
Right. Testicles, alcohol.
Well, yeah, I think that when we look at the entire picture, I think most of us now are much more comfortable about clinically clearing patients.
That's okay.
That I don't send for any study.
Yep.
And I look at them and say, how does your neck feel? It said, fine, until they strap me to this board. Terrific. Those people do nothing.
That's an interesting perspective, because I remember where anybody who came in on a backboard, pretty much in a collar, which was everybody who was brought in by the ambulance, people who was in anything resembling a fender bender,
right.
They would often get x-rays. And I must admit, I personally was not one of them, but I see a lot of people who do that. And so I think that we have gotten much more comfortable saying, you're clinically cleared, you don't need it, sit up, get out of here kind of thing. The next group is people who really do need x-rays, and then and the question is what subset of them really needs the good study? And I think it's really going to just be a matter of judgment. I would agree that not everybody that we send for plain films really should have gone for a CT.
I hope so.
All right, let's moving on.
Because, can I just finish? Because the next step is the people who really know this stuff say 3D reconstruction is by far better than plain CT alone.
I understand.
So we're going to do 3D reconstruction, everybody? I don't think so.
No.
Well, actually, in those studies that looked at 3D, it's real fast, and it's kind of like, well, why don't I get it?
If you've got a new generation scanner with 5 Pentium chips kind of in there.
Yeah, well, I think that this is like everything else in medicine. As the technology changes, our view of what may be the most cost-effective way of handling this will change as well.
It may be in here, but I'm not so sure, where they talk, I think there is a paper in here where they talk about radiologists taking the time to look at people in multiple planes rather than just on a neck, it's this way kind of thing, where they reconstructed and they're looking now at longitudinal views. And in fact, the rules of radiology say you have to look in two planes. And so the idea that you can reconstruct this in a matter of seconds and then look, because these studies, in at least abdominal studies, say we picked up some more stuff by doing that. Now, how important it was, stuff in the neck is likely to be more important than stuff in the belly. All right, let's move on to...
I just want to say that that's 2 abstracts and it's going to be 5 hours. Come on!
All right, let's just then pick up the ones that we like. This paper number 3, actually, we covered this paper in the April issue of Risk Management Monthly. It was kind of a bit of a landmark because you don't see a lot of these done where they look at 122 closed claims relating specifically to emergency medicine. And this paper, like a lot of the others, talks about diagnostic error leading, is at the top of the list kind of thing, diagnostic error. Well, you know, I don't think that's any kind of big surprise. It's usually not on the therapeutic side. You know, I'm not worried about the MI once I've diagnosed it. I'm worried about it when I sit home. So this issue of diagnosis of dangerous diseases is really at the top of the list, as they say here.
Yeah, to amplify that, I'm going to say that we're having the PAs and the mid-levels see the wrong patients. They ought to see the worst people, the major traumas, the big heart attacks. You know why? Because it's almost all pro forma after that point. The tougher patient to see is grandma who says, I'm tired. I'm a little dizzy today. I'm a little weak. I think those require tremendous amounts of medical knowledge and judgment, as opposed to the person who's in there with an obvious broken femur. You know, that's fluids, pain medication, and call the orthopedic surgeon. I don't think those are hard cases. The tough case is the case which is subtle, and that's where the diagnostic dilemma is.
It was very fashionable to talk about systems, and that, well, if we have better systems, we'll have less errors. But the fact of the matter is that's not really true. Honestly, yes, you might not give this drug to this person by mistake, but the fact of the matter is, by giving that drug to the person, you're not going to hurt them. You know, I think that we've got this focus on adverse drug reactions, but the fact is, I think that it's really about cognition. It's really not about systems, honestly. You will never make the diagnosis of bacterial, what is that thing in the back we talked about, this spinal epidural abscess, unless you know about it. You'll never make the diagnosis unless you know about it. You'll never make the diagnosis about aortic dissection unless you think about it in every soul who comes in there. And the same is true of PE, so that we're kind of in the worst first business, and the idea is to approach these patients in a careful way. You know, you mentioned about the PAs. Honestly, we see every patient our PAs see. You know, you don't know where those needles in the haystacks are. You know, it's only a sore throat kind of thing.
Yeah,
you know,
Rick, we see them too. Just understand this. Unless it's like seeing with the first-year residents. Unless you've done the history and physical, you never know them as well.
I think that's true.
Because they can't take the same history and physical that you do. The PAs do
They might take a better one.
They might take a better one, but you know what? You're the one who has the experience in putting that into the bigger picture. I think that you know, we've decided that, the fast track. Believe me, when I look over the experience of the insurance modalities I deal with, fast track's going to have problems in them too. And
absolutely.
And in fact, this week our group finished a case where a guy came in with a little runny nose, cough, chest tightness, 42, no history of anything, into the urgent care. Was treated as I would have treated him, and of course, 8 days later, while working out, he drops dead. I mean, tell me
A cough and runny nose?
Cough and runny nose,
Okay.
well, that was part of it.
What can I tell you?
case.
What can I tell
You
you?
know, one of the things this paper also mentions is that in these cases, at least 80% of the cases had more than one process breakdown and more than one contributing factor. And they talk about the idea that multiple physicians are often involved in these cases. So this gets into the risk of the pass-on case. The pass-on cases, I think, obviously are an issue. And Joint Commission is kind of focused on this whole pass-on business on nursing side, and they like to, focus on the doctor side as well. I think that, we've talked about pass-ons in Risk Management Monthly about how potentially dangerous they are. One of the things that we've asked our doctors to do at our hospital is to physically go. The old doctor takes the new doctor and introduces him to Mr. So-and-so and says, I'm going off duty now. This isn't Dr. So-and-so. He's going to be following up on your case. We've talked about what we're waiting for, what we're looking at, those kinds of things. To present this in some way that the patient says, hey, I got it now, rather than, what happened to my doctor? Oh, he's off duty now, kind of thing. It's discourteous, number one, to do that. And I think it conveys a much better message that we are systematically discussing your case right in front of you, know what's going on, kind of thing. And I would encourage you to think to do that, because if I was a patient and another doctor came in the room and they said, well, yeah, their doctor's off duty, I wouldn't think very much of that.
There are two dangerous times in emergency departments, July 1 and change of shift.
And change of shift on July 1.
Let's move on to number 4. This is
a great paper.
This is about getting into trouble for TPA and strokes. And this paper was written by a neurologist who really understands both sides of the issue, indicating that we understand the people who recommend it. We also understand there's a reluctance. One of the things about this reluctance is it appears that many times you read articles that we're being accused of being not educated regarding these issues. It's like, what's with the emergency doctors? Don't they get it? Don't they understand that this is going to be really important care and the time is brain and we got to go to the stroke center and bypass the local hospital and all that other stuff? And the fact of the matter is that's a very condescending view of emergency medicine. We get it. We read the same articles that everybody else read, and we have some concerns about it. The fact is that this all comes down to this paper saying, what is the standard of care? What is the standard of care? And there is this litigation going back and forth that says it's not the standard of care to give this medication in a stroke. And other people say, yes, it is. So we have the American College of Emergency Physicians, the Canadian Association of Emergency Physicians, the Society of Academic Emergency Physicians, and the AAEM, what is that?
American Academy of Emergency Medicine.
Yes. All of those organizations have taken the position that this is not standard of care. That position apparently has helped physicians because apparently the predominance of the suits are failing to give this stuff. Not that you gave it, that you failed to give it.
And there's a new paper out this week that looks at exactly that question, the suits against emergency physicians, giving it or not giving it, and clearly it was 6 or 8 times greater for not giving than problems with the giving. I mean, there is no question that that's where the suits are. The problem is we actually do not agree. The societies do not agree on what the outcomes really are and the amount of improvement. It's interesting that neurology and American Heart Association, people like that, who aren't down there at that time and not giving the drug, think it's a good idea. I would venture to say in the vast majority of hospitals in this country, neurologists never give the TPA. That's always a decision that is done by the emergency physician. What, are these guys going to drive in, and then in the half hour that they're driving in, you're outside the time window? I think that emergency medicine is the front edge of this thing, and we need to feel more comfortable with it.
Not to do advertising, but there's this thing called Risk Management Monthly.
Can we do that?
We did a whole hour CD on this.
Yes, we did.
In detail. Number 5. Claims, errors, and compensation payments in medical malpractice litigation. This is from the New England Journal from Harvard. Now, these are the guys that have done a series of these articles, and I'll just summarize it and then ask Greg to tell us why this is significant. But basically, the premise here is is a lot of litigation frivolous lawsuits, and they go through 1,452 closed malpractice claims that were reviewed in a blinded manner, looking for error and looking for outcome and looking for whether they thought some of these were frivolous. Now, what they said in this paper was that about 92% of the lawsuits involved some kind of error. 8% of the time, they couldn't really find, after reviewing the charts, any error, but there was a lawsuit. So that's the first thing. They said that compensation occurred in about 56% of cases. So a lot of the time, no compensation occurred, some with a trial and some without a trial. And this is the stuff that I found interesting. That if you went to trial, you are much more likely to win as a physician than lose.
Yes.
But if you lost, you went for a lot more money than if you just settled, to the tune of $800,000, I think it was, versus about $400,000. So it's kind of like Russian roulette. If you go to trial, you're more likely to win, but if you lose, you'll lose big time. And if you just settle, cash will change hands, but it'll be for a smaller amount. They said in conclusion that they don't think a lot of these lawsuits were completely frivolous, as defined by, that we couldn't find anything wrong and this was just made up. So they say most of these lawsuits appeared real. There was some error at least. And then there's a description about what I just talked about, going to trial versus not going to trial. So how do I put this into my practice is what I want to know.
Well,
it's real simple.
Let's get some real numbers here. That most of the insurance companies would tell you that 75% of the money that is paid in your dollar premium goes to the grease of the system. There are very few medical malpractice companies where more than 25, 30% of the money actually goes to an injured party. Wow. It goes to accountants, actuarials, experts. It goes to the running of the company. It goes to this, that, or another thing. As a system of solving a dispute, we have come up with the worst of all possible worlds. We're the only country in the world. After all, there's a lot of countries that use English law. England has abandoned this system for solving the problem, and I don't think it's an efficient way, and to some extent, I don't think it's a fair way to the injured party either. Because what we then do is we get into a mentality of the fortress. We don't want to admit or talk about things, and so there probably are people who justly deserve some compensation. But we can't carry on that intelligent conversation anymore in this country because everybody is lining up their forces and their troops to oppose each other. What it's done is it's made an industry out of something which should have been a compensation program, and it just hasn't accomplished what we want.
Although this paper is important in that, number one, it makes it clear that the vast majority of lawsuits have some element of merit to them, number one. Because lawyers don't want to take these cases. They're going to spend a fair amount of money, and their goal is to win. So they're not going to take frivolous cases. And in fact, frivolous cases, by their nature, are the ones that are disproportionately visible. The guy in Washington who sued the guy who gave him his wrong pants back, that administrative law judge who took his pants to a dry cleaner. They lost his pants. He sued the Korean owners of the dry cleaners for millions of dollars. That was a frivolous lawsuit, but it made the news. There was on the news yesterday. There was a lawsuit, $1.5 million lawsuit, because a flight attendant claimed that a passenger accosted her and bumped her breasts. Nobody else saw it. She sued for $1.5 million. Fortunately, she lost, but that's why they get onto the news. But the other problem is that once you get named, you've got a problem because you cannot depend on justice to prevail. In that, a lot of these suits basically say we can find no error, we can find no harm, and you're still going to lose. And if that's the case, it's Russian roulette.
It's also Russian roulette in that all the evil and bad parts of America come out. Racism, sexism, whatever you want, where you try a case, who's going to be the jury, if there's a loss. Now, in 8% of these, there was no real loss. But let's assume there is a loss. Let's say there's a harm done. That doesn't mean it's anyone's fault. What it means is life goes on and that the death rate is constant, 1 per person. We're not going to stop that. The question is, did you function below a minimum acceptable standard that caused that loss? That's the issue involved here. And the problem is a jury often doesn't understand the medical science which is being discussed to say why we do or do not do certain things. And I think that, unfortunately, the feeling in the country is if we can put men on the moon, we certainly can diagnose every heart attack.
Well, look at
you
this.
Can't do it.
This is really typical. Compensation was awarded for 73% of the claims involving an injury. A quarter of the claims not involving error got money. A quarter not involving error, and 1 in 6 of claims not involving injury. You got money, you were not injured, and 1 in 6 of you got the money. So it's really very discouraging, and I think that's why people are reluctant to take this to the jury system. That's why they push for settlements, because the settlements are generally going to be less expensive, and they're going to be more predictable kind of thing. So anyway, don't get sued.
Article 6 focuses on something that unfortunately this group could talk about a long time, and that is, will physician-level measures of clinical performance be used in medical malpractice litigation? Just what I want to see is somebody bringing in the pay per performance standard saying it took 4 hours and 15 minutes for the antibiotic to be put in. In fact, worse than that, it took 4 hours and 15 minutes before you drew a set of blood cultures or before you took the second set of blood gases or something like that. And so now we'd like to sue. And the prima facie case is because you didn't follow these pay per performance standards, these performance levels, it must be malpractice.
Or that you're a substandard doctor, because listen, you're behind on the aspirin for the ACS, you're not getting these blood cultures when you're supposed to, there's a whole litany of things that you're not up to speed on, and that makes the case that you are not a good doctor. Yeah. So the bottom line is the answer is no, these things are not likely to be used against you.
Well, here's the problem though, Rick. As soon as it becomes commonly known, they're going to bring these things out, and the line of questioning goes like this: Doctor, the government's even said you should be doing X, Y, and Z, and you think they're in favor of good care, don't you, doctor? So if you didn't do that, it must be bad care. And the problem is, we've been cowed and pushed around by government agencies to say that, oh, gee, the drawing of those blood cultures, that's really important, or this is really important, when the truth of the matter is, we can't measure some of the things that are important, so what you can measure becomes important.
That's good. I got to remember that one.
Hey, you got
what
that.
What you can measure becomes important.
That's a good quote.
Yeah.
Okay. Let's skip this EMTALA one. This is just discouraging anyway.
Yeah.
Law enforcement interviews, a conundrum for clinicians. Well, it's a conundrum because, you want to be a good guy, help the cops, that kind of thing. And this paper takes the position that you are the agent of that injured person, whether in fact they were drunk in a car accident, caused a car accident, and getting progressively worse. They hit the kid. So the fact of the matter is that you may be involved in where the police come in and say, we want to interview Mr. So-and-so. And the point that they kind of make repeatedly in this is that you are the advocate of the patient. You are not supposed to be the agent of the police. You should ascertain whether in fact you think the patient is capable of being examined. You should make it clear that it's up to the patient if they want to answer the policeman's questions. That is, you don't care one way or the other whether they do that or not. That medical information should not be shared with the police without the permission of the patient or a surrogate kind of thing.
Yeah, and you don't have to let the police have that information because they can get it if they want with a subpoena anyway. And the smart cops all know this. Rick, I think what this paper is about is very simple. You are a dual agent. You have a responsibility to the patient, and you are also an agent of the state. Every one of us here has reported people for child abuse. We've reported elderly abuse. We've reported domestic violence. We've reported all kinds of things in our role as agent of the state. But while you're treating a patient, the point is, if their medical concerns at that moment are overriding, then you protect them so that you handle their medical concern. Once that's done, then certainly I let the police do their job. I don't want the police to not do their job. I mean, I think that's correct, But what it shouldn't do is interfere with reasonable health care. If they need to be sent to the CT scanner to decide whether they've got blood in their belly, and the police want to interview them, I agree with that. You've got to protect them from that.
Although there's also much more subtle ways where, in fact, they did something, you are upset about what they did, and you tell the police underneath your breath, he's as drunk as a skunk. That you can't do.
That's inappropriate.
But it's so easy to have that happen because you want to see justice done. But the fact of the matter is that you're not allowed to do that.
You're not only not allowed to do it, you've got to be so careful because you do not know all the facts in the case and how many times has your rush to judgment in these cases been wrong. So that's why we have a jury system and that's why we have a law enforcement system. Be careful about these rushes to judgment.
Yeah, I would point something else though. We've done papers in the past that say if you're involved in an auto problem and you've had a little too much to drink and you're at fault, what's the first thing you should do? Grab your neck and ask to go to the emergency department. Because in every study done, your chances of going to jail drop dramatically, and for several reasons. Once they assume your care, then they have to, if they put you under arrest, they're then responsible. The police is responsible for the payment of that medical bill. We see that all the time where they say, when you're done, give us a call, because then we'll put them under arrest. They don't want to do it at that moment in time. Still, people who go to the emergency departments from the scenes of auto accidents, that sort of thing, have a less than 1 in 5 or 1 in 6 chance, as opposed to others who stay at the scene, of actually going and being arrested.
Yeah, another reason that they don't want to do this, that they don't want to sit there for the 12 hours twiddling their thumbs waiting for the workup and then the next guy comes on. There's a lot of institutionalized reasons why the cops do not want to charge you if you're a patient.
Absolutely.
So you remember that when you're hammered next time you drive?
I've got it tattooed on my arm, yes.
Take me to the trauma center.
Yep.
Abstract number 9 is do not roll the videotape. Effects of the Health Insurance Portability and Accountability Act, HIPAA, and the law on trauma videotaping practices. This is from the American Journal of Surgery. And this says, look, we asked people, why don't you record your traumas? Because, you know, it surely would be a very good educational process to video the traumas and then go back and review them with everybody and say you did this well, you did this badly. And as an educational tool, it would be very good. But it turns out that most hospitals, most teaching hospitals don't do this anymore. And when you ask them why they don't do it anymore, it's because they're concerned about HIPAA. They're concerned about breaking people's privacy. Now this goes into lots of detail that says that maybe we don't need to worry about it. Maybe there would be a way to consent people and get permissions and not use identifiers and all this other stuff, because this really is very useful material. But we're not using it because there are groups within the hospital saying you can't possibly do that.
I think there's multiple people concerned about this. Let me tell you what I think is a much bigger problem in the department is not our camera. It's that everybody now has a camera. Everybody's, well, not mine, but everybody's cell phone is now a camera. We've had people snapping pictures of people across the way who were bleeding and things like that, sending them to their friends. I mean, basically the rule is we don't want you taking pictures in the department simply for that reason. We do have privacy issues, and that is a reasonable thing to protect. By the way, what are you now going to do with the tapes? Are we going to tape every trauma? At the end of 30 days, are they going to be erased? I mean, is this now going to be something that can be held over your head that you erased it because it showed your negligence? These are not simple questions.
Can you make it non-discoverable by putting some label on it, like you do for M&M, like we discussed this case, we use it for education,
well,
it's not discoverable?
It depends on the state you're in. If you're in the state of Nevada, that would never work, because in Nevada, even quality assurance materials are discoverable and admissible in court. In the state of Michigan...
Is that why nobody practices in Nevada anymore?
Nobody practices well, that's right, exactly. In the state of Michigan, if it's properly labeled, it could be non-discoverable and non-admissible. So I think it depends on the state that you're in, but just understand when you have a record out there, very few lay people would understand all the things that happen during a code. What they've watched is the sanitized version on ER. Remember, when they're on their way to the operating room in 7 minutes or 6 minutes, that sort of thing? That sort of thing doesn't happen in real life, and we just need to deal with it.
It's interesting, I was just in Australia with my people, and the biggest trauma centre in Melbourne, which is a big trauma centre, it's 4 million people there, they are now videotaping every single code and doing exactly this. They're looking at them, they're showing the nurses and everybody, and they're doing a general consent. If you come to this trauma centre, you will be videotaped. We won't spread it out there, but we'll use it for education.
And maybe there's a less of a malpractice kind of environment
Well, actually,
there.
they're catching up now.
Yeah, yes.
They are
Well, but
catching
the other thing is the Australians are maybe a more advanced culture. We have no way.
In so many ways.
I
In
doubt
so
that.
many ways,
I doubt
yes,
that very
yes.
much. You know,
Very good.
they're growing up from their children are like related to the kangaroos and the wallabies. And the,
Wallabies, right? Yes.
Physician reporting of medically impaired drivers. For us in California, that's kind of a big deal because it's mandated. But this paper says 6 states have mandatory laws. I guess we're one of them. 25 states have permissive laws that says you can do it, but it is not mandated. And 19 states have no laws regarding physician reporting of medically impaired drivers. It's very inconsistent, you know. We should report every intoxicated driver that comes into the emergency department.
Well, that's what the state of Hawaii said.
That's much more dangerous than reporting, seizure patients in terms of when you look at really the outcomes. So in California, if you don't, then you are breaking a state law. You can be fined and this, that, and the other thing. And the other,
it's a misdemeanor.
And the other issue is your malpractice insurance will not cover you for that because you cannot insure yourself against breaking a law. So that becomes a matter of some import here in California.
Well, there's arguments clearly in favour and against these mandatory reporting laws. The arguments in favour is, well, maybe it will stop the person who's got a seizure disorder crashing their car, but people have argued exactly the opposite. If you develop a seizure disorder or you're starting to have syncope and you're 80 years old, you don't want to go to the ER and get checked out or go to your doctor because they're going to report you and you're not going to be able to drive your car and you're going to lose your job. And so there are arguments for and against this. The biggest argument against it is that for some of these things, it really doesn't increase your risk of crashing your car very much at all. But we have to mandatorily report you, and this is a big deal.
By the
and
way,
like you say, compared to alcohol, alcohol is by far the biggest risk.
Alcohol is 10 times, 20 times. In fact, there was a study, I think we've done that paper, about seizure patients over years, about what their actual incident risk is of being in auto accidents, no different than the public at large. And I think that that was way overblown. In the state of Michigan, we are obligated to notify them when they've had a seizure that they should not drive for the next 6 months or until seizure free. But there is no place to report them. See, here you have to send something to the Department of Motor Vehicles or something like that. Yeah, we don't have any place to report it, so we tell them that, and then we all know that the next week to go to the seizure clinic, they drove in. They drove in, of course. Yeah.
Actually, that extends to something else. I just saw something from the Epic Insurance Company, Graham Billingham's company, and it was about a case in which somebody got sued because they were driving a car and actually hit a child, I believe it was, under the influence of medications that were given them. And the whole thrust of this was that you have an obligation. You can't just the pharmacist will label the bottle, do not operate heavy machinery. I always envision the guy coming up and doing like a D10 Caterpillar tractor, okay.
Rick, interesting enough, we did in one of the episodes of Risk Management Monthly discuss duty to third parties.
Yep.
And you have a duty to a named third party, the one in front of you that you know about, or it's easily predictable, i.e., if you're treating a man for gonorrhea, his wife is a predicted third party victim. You must warn about passing on a disease. But then there's the predicted but unnamed, and that is if you put them on a motorcycle and they're full of Vicodin, the chances that they're going to hit a kid crossing the street or something like that. Just so happens that for next month's issue of Risk Management Monthly, we actually have 2 cases of that we are going to discuss.
Well, actually, Graham's advice was to put in the chart,
warn,
patient advised regarding don't drive D10 bulldozers. I mean,
heavy machinery. So, if you've got a Civic that's light, you don't have to worry. If you've got
no, and it does make some sense because the first thing they're going to do is deny that you ever said it.
Right.
There's not going to be any record of it because you never wrote anything down. You relied on the pharmacist to do this, and you know that's may or may not be a reasonable thing to do. It generally is, but you know, but the doctor never said anything to me about it. I never read those labels on those bottles.
And by the way, the negligence of the pharmacist would never excuse your negligence.
That was the other point that they were making. Yes. So this is one more thing you get to put in the chart now. Every time you're going to give out some narcotics or
just
something like that.
Just warnings given. When you're dictating it, warning given. And I think that that's all you need, because then they ask you, well, doctor, what do you mean warning given? This is my usual and standard warning which I give. By the way, all of our materials now, we have a computer that does the discharge. When we call up that drug, because it's going to print the prescription, it gives them the piece of paper with the 4 or 5 major warnings right on it. You can't print out the Vicodin prescription without the warnings being attached to it. And I like that. I think that that's the way to go.
You ever seen the trash can outside your department?
Rick, there is no question.
Full of warnings.
Of course it's full of warnings.
But you gave it. I
tried.
I got it. Want to do 11 or we have about 15 minutes.
Okay.
Does anybody know 11? We never got this far before, I don't think.
No.
The reason I thought we should try to do it is because the August issue of Risk Management Monthly is about the management of low-risk chest pain patients, something which we have been dodging for over a year because it's so difficult, but we are going to tackle it in August. This is about fears about this, and basically it basically says that if you have a lot of fear about missing these MIs, that you will admit a lot more patients than those of your colleagues who have less fear about it. And I don't know that that's pretty part. It's exactly
now, in all fairness, this goes throughout our entire lives. There are people who are risk averse, and those people who are willing to take more chances. There's no question about that. But still, with everything we know, about a third of the lawsuits in emergency medicine have to do with chest pain.
So we are going to cover that. We did already cover, for those of you who are not subscribers, you should know that once you subscribe, you get all of the back issues in terms of you can download them in our news little thing. Because the other issue was the cases of aortic dissection, which we already have covered. That's an easier one. What else did it say in this? Anything else interesting in this paper that we can? Troponin testing was performed for 80% of the patients treated by high fear doctors, compared with 74% for low fear doctors. Well, that's hardly any difference.
It's almost no difference.
The same was true for chest radiography. So they did the same test, but they came up with different conclusions. You need to come in the hospital. You can go home. One of the things that is really pretty interesting is that the Heart Association, in conjunction with the American College of Cardiology, has come up with some very specific recommendations regarding these low-risk patients, and it'll be very interesting to see whether, in fact, what they're recommending is, in fact, standard of care in the community, because I think the answer is no, it's not.
I think we're looking at the world as two groups, those who go home, those who get admitted to the hospital. There's clearly going to be a third group in a lot of these things. Those who are worked up in the chest pain center or something for 6 hours. That has to do with syncopal patients. It has to do with TIA patients. I remember when TIAs all got admitted. Now we can get them in, get the studies done, get them gone in 8 to 10 hours, and we kiss them goodbye because there's nothing more we're going to do. I think the same's true with chest pain. If you can move them on, in fact, one of the papers we did earlier on, Rick, talked about if you've had 3 sets of negative enzymes and 3 negative EKGs or no change on EKGs, your chance of dropping dead in the next 30 days are less than 1 in 1,000. Mm-hmm. We can't put everybody in the hospital. And as you're looking at a growing elderly population, which we are, I mean, I'm sitting next to him right now.
Speak for yourself.
He's growing and he's elderly. As we look at this, we can't put everybody in the hospital. And so I think this concept of hospitalized or not hospitalized is not the right way to look at it. There's going to be intermediate steps, which we're going to be able to do.
Well, stay tuned for the August issue of Risk Management.
Yeah, I couldn't wait.
12? This is a recurring theme in the literature. It's about malpractice suits and doctors who have, well, there's a couple of trends in the literature on this. This is entitled The Relation of Patient Satisfaction with Complaints Against Physicians in Malpractice Suits. And it basically concludes that if you have complaints against you, you're more likely to have malpractice suits. There is a relationship, whether it's one-to-one, not necessarily, but so complaints are a marker of malpractice suits. So are previous malpractice suits. We had a nice couple of papers that basically make it very clear that where there's smoke, there's fire, and if you've been named 4 times, I'm really going to be very concerned about you when we talk about hiring you.
As the president of an insurance company, let me just tell you, whenever a doctor says to me, I've been sued 5 times, but I've never lost, what I always say back is, no, you've lost 5 times. It's just how much money was paid at that moment in time. By the way, did they ever give you extra money? No. So if it cost us $60,000 or $70,000 to get him off of that case, times that by 5 and tell me that he hasn't lost any money. You know, what this basically says is my good half Swede, half Dane mother, who went to the 8th grade, said something where she said, Greg, you know, if people like you, that's a good thing. You know what? She was right. You'll forgive people anything if you liked them. And you and I, we all know this. They've got a doctor who has done something on the outside, and we're listening to the story and we can't believe it, and they love this guy. They love him. They'll never sue that guy. And yet, if they don't like you, they have only one way of taking out that vengeance when something goes wrong, and that's with an attorney. That's the socially acceptable way of carrying out anger.
Abstract 13 is mandatory reporting of domestic violence, friend or foe. It's from Mount Sinai Journal of Medicine in July of 2005. And this is kind of like what we talked about before. This is another one of those mandatory reporting pluses and minuses. The upsides is that it tells people out there that, you know, domestic violence is bad. It removes the onus from the person who's getting abused so that they don't have to have this burden of trying to decide if they should or shouldn't tell on this person who's beating them up. And maybe it reduces death and harm. And then the opposition argument goes the other way. It says, look, this reduces the patient's autonomy. Maybe they're smarter than you about when they should or shouldn't be telling the police about this. It reduces their confidentiality. Look, I told you this, doc, in confidence. Now you're telling me you're going to go tell the cops? That's bogus. I'm not telling you anything else. It may also actually increase harm to the patient. So this woman usually is trying to work it out, and now the cops come over and say, hey, mister, you're going to come with us. They can't put him in jail because there's not enough jail spaces anymore, and he comes home and he beats her up more, he kills her. So these are some very interesting arguments on both sides of this mandatory reporting quagmire that we find ourselves in, and there's actually very good arguments on both sides.
Yeah, I think that it's very clear. The more I've looked at this, the more I see both sides of this issue. I tend to be a law and order guy. I think we ought to be reporting, but here's what I think needs to happen, is your county systems have to work. Where it falls apart is where the woman doesn't have a place to go, where they don't pick the guy up, you know, eventually. If I'm in a situation where I've got excellent law enforcement backup and things to go, reporting works just fine. When some of these counties are so backed up, I don't know what it's like in LA County, but I'm sure LA County may be backed up for a month in processing these things. In a month, he can be drunk again. He can be over again. There can be problems. But I certainly understand that argument that says this is officially the society putting you on notice that you shouldn't be involved in this kind of activity again.
Actually, there was an article a couple months ago, I think it was in the Annals of Emergency Medicine, that tried to look at what were the sequelae that occurred after somebody reported domestic violence in the emergency department. And the conclusion was that it was exceptionally benign. So
Yeah.
this idea that, although other people don't necessarily believe that, this paper did come out and say that California is a mandatory screening, mandatory reporting state, which is really, really, really a problem. For a variety of reasons. First of all, you know, patient autonomy. I'm here for a sprained ankle, and it's frankly none of your business about who's beating who up here. And I think you're asking questions that are outside. Now, the people who feel comfortable screening for domestic violence say, no, you're going about it all the wrong way. You just say, this is part of our routine intake process. We ask everybody this. I'm not asking you in particular, kind of thing. you know, that's okay, but
Yeah. You don't start out the conversation by, is your boyfriend still beating the crap out of you, yes or no?
Yeah. I do have some problems with it, frankly. I think it would be great if ERs had signs all over the place that saying, listen, if you're having some issues here, we'd be happy to discuss it with you. But for a person who's there for a tetanus shot to say yes or no kind of thing, I think that's another issue.
Well, also, you got grandma there, she's 80, her husband's there, they're fine, there's no marks, there's no nothing, and grandma's in for a pneumonia, and you say, does this guy sit next to you, does he beat the crap out of you ever? I mean, I think that there is some place for physician judgment or nursing judgment in deciding who you ought to ask that question to.
Well, technically, you're supposed to be asking the men as well.
Well,
it happens.
I'm an abused. I'm an abused husband. I'll admit
abused,
it.
You know?
I'm badly
Credit
abused.
card abuse. It's very rampant.
Of course, my view of abuse is being forced to drink a domestic Beaujolais. But then again, everybody's view is different.
All right, so we got that one out of the road. Basically says we have no idea what to do there, but that there are going to both sides. What constitutes the standard of care? That would give Greg.
This is MP's article.
It gives Greg an hour right there.
Yeah, at least. But points out the fact that this is a person who's written in Washington University, is talking about what do doctors really know about the term, the standard of care, because you see, it's not a medical term. We don't use it in medicine when we talk to each other, because to us, we understand that there are lots of ways of skinning cats. There is no one way, and it changes day by day, month by month, as new technology comes out. So what is the standard of care for a STEMI at this moment in time? Pretty much depends on what period of time we're talking about. The other thing is a standard of care is that which the average physician of like or similar training might do under like or similar circumstances. So what would be the standard of care in Ishpeming, Michigan, which is a 100-bed hospital at 2 o'clock in the morning in the middle of the winter, and what would be the standard of care at the Mayo Clinic at 2 in the afternoon might really be quite different depending on what resources you had available. I mean, if you have a cath lab ready to go, that might be different than somebody you have to put in an ambulance and ship for an hour and a half to have a study done. And I think that the term standard of care is bandied around as if there was one standard of care. From a legal standpoint, standard of care is set at each trial by expert testimony from the stand. There is no one thing that sets the standard of care.
So there's no point in me writing a book called The Standard of Care.
Well, funny you said that, because a nurse actually wrote a book that said the standard of care in emergency nursing. I thought, if I had to pick a bad title, a title which was inappropriate, that would be the title.
I think it's a great title. Everybody will buy that book. All the lawyers will buy that book.
Every lawyer. You know, there's somebody who has on a disc every major recommendation by the 24 major medical societies and their standards, they're this, they're that. And they called Neil Little, my partner, and said, would you like to buy this? He says, no. But he said, who does buy this? He says, oh, attorneys. No doctors actually buy these things.
And last but not least is number 15, Defensive Medicine Among High-Risk Specialists in a Volatile Malpractice Environment, published in JAMA. This is a survey of a bunch of different kinds of doctors, 842 of them, so only 65% responded. Most of them had been practicing for more than 10 years. They were all kinds of different doctors. They were neurosurgeons, general surgeons, orthopedic surgeons. Why are they all? They're all high-risk kind of doctors.
Yeah, yes.
Where's the pediatricians?
They're high-risk specialists.
They're high-risk
specialists.
specialists.
That's what the title says it. Okay.
The title says it, yes.
And as you might anticipate, all of them acknowledge concerns regarding malpractice and limiting their scope of practice and likely to do so within 2 years, and more than half have repeatedly ordered medically unindicated tests and unnecessary referrals, and about a third reported prescriptions of more medications than medically indicated and suggestion of unnecessary invasive procedures, etc. And I think, honestly, this is a self-serving kind of survey. I mean, it is proper for doctors to say, oh, absolutely, absolutely, I've changed my practice substantially kind of thing. I wouldn't expect anything but this kind of answer, because frankly, it is self-serving.
Well, no, but it's frankly, it's true.
Well,
you've never ordered a test just because you're worried about medical malpractice?
The idea here, Frank, is, and I believe, is to kind of make it clear that there's huge dollars being wasted in all of these unnecessary tests because of risk management. And I know that this is unpopular, but I believe that in California, the number of lawsuits has dropped dramatically since we have this 250 cap on payment.
I think it stopped when you stopped seeing as many patients, Rick. Yeah.
And that's the number of lawsuits way down. And in fact, on the Risk Management Monthly, we talked about the fact that people who have very legitimate suits can't get a lawyer to take them because if you kill the person, there's no money in it for them, and so that children and elderly people who have both ends of the spectrum who wind up dying as a result of misadventures are not worth anything, so lawyers don't take them. So, you know, I think that this is one of those things where even when there is much less malpractice, I don't see any difference in physician behavior in this state. You get these risk-averse doctors who order everything, do a workup.
Yeah, but there's lots of forces at work. It's not just lawyers, it's how you were trained. And the question is, if we radically change the system from beginning to end, from medical school through, and said you can just do the right thing now and you're not going to get in trouble, you're not going to get sued, and we can, that's the real, if we totally change the system, then would it reduce physician ordering of inappropriate tests? And I think it would change it tomorrow.
I think it would change it dramatically, but we make a mistake when we think that medical malpractice, the amounts that given in awards and the amount paid for insurance are the big dollar costs in the system. They're not. It's doctor behavior, which is inculcated from medical school on, where all of these things are subtle forces. I think the other thing that's happening, and you'll have to excuse me for this, being an old guy, I think that I was from the generation of wooden ships and iron men. Tough guys. We expected to be busy 70 to 80 hours a week. What you're now seeing is a group of people coming out of the residencies, the Xer generations and the O generations and the whatever they are now, Y, that want more controlled lifestyles. And one of the ways you get a controlled lifestyle is to do what? Limit your practice. So now all these neurosurgeons want to do is elective backs. Do you honestly think they want to drive in to see a kid who's got a subdural from a motorcycle accident, who almost by definition has a bad outcome waiting to happen? Do you think any orthopod wants that case or neurosurgeon wants that case? The answer is, I think as physicians as a whole are changing their practice. Find me a place where it's easy to get people on call now to come in. And I remember you guys were way ahead on this. California, you were getting piss asses who weren't coming in long before we were. Now in old staid Michigan, you know, old school medicine, we're now seeing the next generation who basically says, you know what, they don't pay me enough to come in at night. I ain't coming in. And I think this is a sad time for medicine, I really do.
Well, I think we would probably all agree that if there was a substantial change in the malpractice environment, gross, substantial, huge change, that there would be less testing. I think where we probably disagree is the magnitude. Mm-hmm. I think doctors now actually are starting to believe that that's called good medicine.
All right.
And I think that's a problem.
It's a re-education needs to be.
Yeah, right.
Because they've been taught by the generations of people that have done all the tests because they've been afraid, and
well,
we need to start again.
But
let's
just
wipe it clean.
It's not even just that they're afraid. It's they honestly believe. I mean, I see residents all the time in general surgery who think I have to have a CT scan of the abdomen to take out the appendix, and that's crazy.
I gotta believe at USC where the emergency medicine residents are, they're ordering stuff by the truckload.
Oh, they are.
And the fact is, and they say, well, why? This is a teaching environment. What are you teaching? You're teaching to
bad
order
habits
stuff by the truckload.
Yeah. What's
I never got it.
is the practice variation. And I know you sit at your place, and it's true. We have attendings who order nothing, who take a history physical and say, get that chest pain patient out of here.
Exactly.
And there are other ones that, like, if you have a chest and you're in our emergency department, you never get discharged home. And then there's a
the pizza delivery man gets worked up for ACS.
I was just walking through. No.
I saw you go like this.
Could be a silent infarction.
Could be a silent infarction.
You never know.
Right. Well, Rick, does that bring us to
That's an hour,
end?
man. That's it. Thank you very much for your perseverance with us.
That's right. Did you fall asleep? Probably.
Bye.
See ya.